Hello, my name is Iftikhar Kalu, and I'm a professor of medicine in the Department of Cardiovascular Disease and also a consultant in the department. Today, I'm going to give an update on familial hypercholesterolemia, which is a relatively common Mendelian disorder that is associated with a high risk of adverse cardiovascular events. This is the outline of my talk. I'll be first starting with a historical perspective and describe the genetic basis of this disease. I'll describe the presentation, clinical criteria, and the associated ASCVD risk, the burden of FH in the community, the merit of Cascade screening, and then how we can manage these patients with drugs. Let's start with this case, which illustrates the dramatic and often unexpected presentations that can be manifest with FH. This is a 35-year-old woman with ST elevation who presents with ST elevation anterior myocardial infarction. And on physical examination, she has these stigmata that are characteristics of familial hypercholesterolemia, including tendon xanthoma, particularly near the Achilles tendon, as well as arcus senilis seen here in this picture. When we take a family history, we note that her mother died at age 50 of coronary heart disease, and her son later turned out to have high LDL cholesterol of 271 milligrams per DL. Her lipid profile is shown here with a total cholesterol of 338, an LDL cholesterol of 285, an HDL of 31, and a triglyceride level of 114 milligrams per DL. Her lipoprotein A was significantly elevated at 190 milligrams per DL. The first reports of FH, interestingly, came from dermatologists in the early part of 1930s, and they noticed an association of xanthoma, high cholesterol, and myocardial infarction. And the first report was published by Muller, a Norwegian physician, in 1938. In 1964, Kachadurian performed segregation analyses in a large Lebanese family that suggested that there was a single gene defect responsible for the very high cholesterol levels in this family. In 1967, Fredrickson at the NIH further elucidated the low role of lipoproteins in atherosclerosis. And in 1974, Brown and Goldstein presented their important work describing the molecular basis of FH and incriminating defects in the LDL receptor as being the most important cause of FH. And they, of course, went on to win the Nobel Prize for this work. As a genetic disorder, FH manifests locus heterogeneity, allelic heterogeneity, as well as varying penetrance. Now, what do these terms mean? Locus heterogeneity simply means that different loci across the genome can cause FH, and we know that several genes rather than a single gene are responsible or can cause FH. Allelic heterogeneity means that there is not a single mutation in a gene that's responsible, but several mutations in one gene can be responsible. In fact, in the LDL receptor, more than 2,000 mutations have been described, of which about 60% are deemed pathogenic. There's also varying penetrance. In other words, the person or a patient can have the mutation, but the LDL level may not always be very high due to other factors that I'll describe in a moment. And of course, it's autosomal dominant, and you can see the characteristic pedigree where nearly half of the affected first-degree relatives are affected by FH. Now let's watch this animation which depicts LDL levels in the circulation or particles in the circulation binding to the LDL receptor on hepatocytes being internalized and then being targeted for degradation in a clathrin-coated vesicle that ends up in the lysosome. And here we see that the cholesterol component is degraded, whereas the LDL receptor gets recycled back to the surface where it then can function again and remove LDL particles from the circulation. If there's a sparsity of LDL receptors, then the LDL levels go up. And if there's an excess of LDL receptors, and the LDL cholesterol levels will go down. So it's a very tightly regulated system by the liver. Now, on this cartoon are illustrated the 3 genes that are incriminated commonly in FH. The LDL receptor gene, the apolipoprotein B gene, and PCSK9. Now, loss of function in the first 2 genes results in impaired LDL uptake by the liver and therefore increased LDL cholesterol levels. Interestingly, in PCSK9, it's actually a gain of function mutation that leads to decreased LDL receptors and increased circulating LDL cholesterol levels. And this is because the LDL particle, after it binds to the LDL receptor, is internalized, as I showed in the previous animation, and then the cholesterol is degraded, but the protein, the receptor itself, is recycled back to the hepatic surface. Now, PCSK9, when it's bound to this LDL and receptor complex, targets the LDL receptor for degradation as well, with the result that the density of LDL receptors on the hepatic surface goes down and LDL cholesterol levels go up. Now, what's the typical clinical presentation of a patient that we are suspecting to have FH? Often these individuals will have a strong family history of early onset adverse cardiovascular events, or the patient himself or herself may have had premature ASCVD, most commonly myocardial infarction. On exam, they will have features of that are pathognomonic, xanthoma, arcus, senilis. Often patients may have aortic sclerosis or stenosis because of the high LDL levels, and this is particularly prominent in those that also have concomitant increase in the lipoprotein A levels. One should consider additional testing, such as measuring the lipoprotein A level if not already done so, assessing subclinical disease burden, for example by coronary artery calcium scanning, echocardiography to assess the aortic valve, and then stress testing to assess if the patient has inducible ischemia. Now, the presentation is modified by several factors other than the LDL cholesterol, and those are listed here, and they include metabolic factors, environmental factors, whether drug therapy was instituted and at what time, the characteristic of the particular mutation in LDL receptor, other genetic factors that would be called modifying factors, and whether there's elevated lipoprotein A level. Now, the clinical diagnosis is established based on criteria, and there are 2 commonly used criteria for FH. The first is the Dutch Lipid Clinic Network criteria, which essentially gives a score for several factors that are listed here, including the extent of plasma LDL elevation, whether there's family history of ASCVD or high cholesterol, whether there are signs on physical exam of xanthoma or arcus senilis, whether there's a personal history of ASCVD, or whether a positive genetic test is available. Another set of criteria are the Simon-Broom criteria. Here, the important central criterion is total cholesterol that's elevated to greater than 290 in an adult or greater than 260 in a child, and LDL that's greater than 190 in an adult or greater than 155 in a child. And then for definite heterozygous FH, tendon xanthoma in patient or patient's first-degree relatives, or the availability of a positive molecular genetic test. It's probable heterozygous FH if there's family history of myocardial infarction at an early age, or there's history of elevated cholesterol levels in the family members. Now, homozygous FH is a severe form where there are 2 mutations present, either in the same gene or in different genes that I alluded to earlier. Here, the plasma LDL-C levels are often greater than 500 milligrams per DL. Although a criterion of greater than 400 milligrams can be used if there's presence of concomitant aortic valve disease, or there's onset of tendon or cutaneous xanthoma, at an age less than 20 years. A threshold of 300 milligrams per dl can also be used if these levels are present in the face of lipid-lowering treatment, or there's family history of hypercholesterolemia, or presence of tendon or cutaneous xanthomas at age less than 10 years. As I mentioned, often these individuals have two mutations in the FH-related genes, LDLR, ApoB, or PCSK9. And this picture shows the dramatic deposits of cholesterol in the skin manifesting as xanthoma around the tendon areas. Now, the prevalence of FH has varied from 1 in 600 to 1 in 200, depending on how the disease was ascertained. We undertook a study called the Screening Employees and Residents in the Community for Hypercholesterolemia in Olmsted County. We took our cohort of employee and community health individuals that has about 138,000 adults or individuals in it, and we identified about 6,500 individuals that had an LDL cholesterol of greater than 190 with a triglyceride level that was less than 400. We then excluded individuals that had secondary causes of hyperlipidemia, and we ended up with nearly 6,000 individuals, which is a remarkable prevalence of about 4% in this cohort. We next went on to assess how many of these individuals actually met criteria for FH. And 1 out of 14 individuals with an LDL cholesterol of greater than 190 had met the clinical criteria for FH. However, only half of these had an ICD-9 code that was related to cholesterol. And an LDL level of greater than 100 milligrams per dl on treatment was achieved only in about half of the individuals. So these data clearly outline the gap in awareness, detection, and control of FH. And thus, much more needs to be done in this realm. One way we can improve in this area is by cascade screening. And this is a typical family with FH where the proband was tested for cholesterol levels after her father died suddenly at age 65. She indeed had elevated LDL cholesterol and met the criteria for FH. And then other first-degree relatives were screened, and one of her 2 siblings also turned out to have FH, as did one of her children and her brother's children. So one can see that if we identify the proband and then go on to cascade screen the relatives, we can identify additional relatives that may benefit from early treatment. Now, how should we do this cascade screening? Well, one group favors LDL cholesterol measurement, another group favors doing the actual genotyping. I would favor the latter because of the data that are shown in this slide, where mutation-negative relatives of patients with FH were compared to mutation-positive relatives. And you can see there's a substantial overlap in LDL cholesterol levels in these 2 groups. Of course, they're higher in those that are mutation-positive, but nonetheless, the overlap is significant. And hence, LDL cholesterol levels by itself may not be able to identify an affected first-degree relative. So in the CV Genomics clinic, one of our goals is to indeed identify first-degree relatives of the proband that might have FH. So once we have the patient seen in the CV Genomics clinic, we will have a genetic counselor draw the family pedigree and counsel individuals regarding genetic testing. The relatives are then contacted directly via the index case, and all the relatives can be then seen in the clinic and offered a DNA and lipid profile. When FH is confirmed, appropriate therapy is recommended, and this can be done in the CV Health Clinic, or the patient can be referred back to their primary care provider. Now, such an approach allows an unambiguous diagnosis in relatives and for further cascading. And in the Netherlands, this program has worked quite effectively, and in terms of cost per life of years gained, it was a very acceptable $8,700. This program has been in place in that country for more than 10 years, during which time 20,000 cases have been detected. A really spectacular success in public health genomics. Unfortunately, in countries such as the US, where the health system is not centralized, cost effectiveness for Cascade genetic testing has not been assessed. How do we manage patients with FH? Well, there are two categories of drugs broadly, those that affect on hepatic metabolism and those that act on the intestine. Let's start with the liver here. And of course, the central modality would be statins. They inhibit HMG-CoA reductase and reduce cholesterol production in the liver, which then in turn leads to increased LDL receptor expression on the hepatocytes. Mipomersen is a new drug that is an antisense for apolipoprotein B100, and that then leads to a decreased production of VLDL-like particles. And microsomal transfer protein inhibitor lomitapib also acts similarly by reducing the production of VLDL atherogenic particles. A new class of drugs that target the PCSK9 protein that I alluded to earlier has emerged and been shown to have significant LDL reduction properties. Two drugs, alirocumab and evolocumab, have been approved by the FDA in 2015 for patients who have FH and are not at goal in spite of maximal medical therapy or have statin intolerance. These drugs act by inhibiting PCSK9 and thereby reducing the degradation of LDL receptor, which are then able to recycle several times, in fact up to 150 times, and therefore efficiently lower LDL circulating levels. Two drugs that act on the intestine are ezetimibe, which inhibits the NPC1L1 protein and reduces cholesterol absorption, and then colesevelam and other bile acid resins that bind bile acids and then in turn lead to increased expression of hepatic LDL receptors. So once we have an individual with suspected FH and ruled out secondary causes of elevation in LDL cholesterol, we then attempt to establish a clinical diagnosis based on the features I alluded to earlier. We may consider additional testing, and then the patient should be referred to the CV Genomics clinic, where genetic testing and cascade screening can be started, counseled on lifestyle changes. And then lipid-lowering therapy is focused on statins, and then ezetimibe can be added if the goal LDL cholesterol is not reached. Newer drugs that are available include the PCSK9 inhibitors, as well as mipomersen and lomitapib. Bile acid sequestrants, niacin, can occasionally be used. And then the role of lipoprotein apheresis has diminished recently because of the availability of the PCSK9 inhibitors. Now in children, statins do not appear to affect growth, maturation, and educational levels. The drugs can be started as early as 8 years, and both pravastatin, simvastatin have been studied, as well as pitavastatin, in particular in children of Asian descent. A goal is to reduce the LDL cholesterol to less than the 95th percentile, or less than 130 milligrams per DL, or have a greater than 50% reduction in baseline LDL levels. Ezetimibe or colesevelam can be started from age 10. In the rare patient with very severe FH or homozygous FH, lipoprotein apheresis is an option. Now at Mayo Clinic, we have initiated a CV Genomics clinic to manage patients with familial hypercholesterolemia. The patients are assessed by a genomic cardiologist as well as colleagues in the CV Health Clinic, and then they meet with a genetic counselor for pedigree drawing, counseling about genetic testing, and obtaining pre-authorization for genetic testing. Once these results are back, they are reviewed by the genomic cardiologist. If there's a pathogenic variant, then obviously the diagnosis of FH is confirmed and the cascade screening of relatives can begin. Occasionally we'll see a variant of uncertain significance, and we are in the process of developing functional assays that will help us determine whether this variant is truly, or better understand the significance of such variants. If no pathogenic variant is identified, patients can still be considered to have FH because genetic testing is negative in 20% of individuals that meet the criteria for FH. We are exploring the use of whole exome sequencing in such families to discover new genetic etiologies for FH. So to summarize, FH in 2016, we continue to unfortunately have low awareness, detection, and control for this condition. Some of this may be addressed by the availability of a new ICD-10 code for FH. There is a lot of data suggesting that cascade screening by genetic testing may be cost-effective and prevent adverse cardiovascular events in family members that are affected but asymptomatic. Intensive LDL cholesterol lowering should be started as early as possible. In fact, in children who are affected with high levels, treatment can be started with a statin, ezetimibe, or colesevelam as early as 8 to 10 years. Novel therapies have a promise for high-risk severe FH patients, and these include PCSK9 inhibitors. I want to end by acknowledging my laboratory colleagues as well as funding agencies, and I would like to thank you for listening to this talk, and I hope that the information presented will be useful in your practice.